Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
You're listening to Healthcare Matters, the podcast that pulls back the curtain to help you make sense of complex healthcare economics and policy issues. With us is Dr. Robert Popovian in Washington, D.C. He's a pharmacist, an economist, and the Chief Science Policy Officer at the Global Healthy Living Foundation.
And joining me, as always, is my good friend Ben Blanc, dialing in from Indianapolis, Indiana, who is our Associate Director of Digital Production and Engagement. Ben, how familiar are you with the French healthcare system?
Well, see, I was born and raised in Paris, France, and I also worked for 10 years there. So I'll say I'm pretty familiar with it. I've now lived in the US for several years, and I know the French healthcare system is in constant evolution. But if that means you'll be quizzing me about it, I can absolutely give you a rundown.
Well, that's a good thing, because latter part of this podcast, we're going to come back to you because we want you to explain a little bit of the differences in the French system versus the US system and how perhaps adopting some of the principles that the French system has will benefit patients and the ability for them to receive care in the United States.
Well, happy to, and I won't be the only one sharing my perspective today, since we have a guest with us, Corey Greenblatt, who's the Director of State Policy and Advocacy at GHLF. And today, we're taking a closer look at the Advisory Committee on Immunization Practices, or ACIP, and how their proposed RSV guidelines could impact vaccine access for patients with chronic conditions. GHLF recently submitted a letter to ACIP to share our concerns and recommendations for improving these guidelines, and that's where Corey comes in. So let's dive into it.
Hi, Corey, first of all. And secondly, Corey also presented at the ACIP meeting. We were one of the only patient organizations which was allowed to present, and he did a fantastic job at the advisory meeting.
Thank you both for having me. I'm excited to be here and happy to talk about the work that GHLF is doing with regards to vaccine advocacy, because it's a really important space that we are trying to have an impact on.
Well, thanks for joining us, Corey. And we'll get back to you in just a minute. I just want to ask Robert to start us off. Could you explain what ACIP is and how its guidelines impact patients, especially those with chronic illnesses?
So, yeah, we need to go back and give a little bit of a history lesson. As you mentioned, Ben, Advisory Committee on Immunization Practices, also known as ACIP, was chartered as a federal advisory committee to provide external advice to the Center for Disease Control, CDC, and the Secretary of Health and Human Services on the use of vaccines in civilian population in the U.S. In 1964, CDC made the first recommendation for a vaccine for adults, and the recommendation involved the influenza vaccine, where persons with certain risks and complications were basically recommended to receive this influenza vaccine. Since then, obviously, it has provided immunization guidelines for pediatric patients, for adult patients, for a variety of vaccines. And ACIP recommendations are based on expert consensus data, and they also utilize cost-effectiveness data to come up with their conclusions of which vaccines they recommend.
Well, thanks for setting the stage, Robert. With that understanding of ACIP's influence, let's talk about GHLF's specific concerns regarding the proposed RSV guidelines. So, Corey, you were recently invited to speak at an ACIP advisory meeting, and I also read the letter that GHLF submitted to comment on ACIP's proposed RSV guidelines. So what did GHLF say in that letter? Could you walk us through the main highlights of GHLF's feedback?
Sure. Happy to talk about GHLF's point of view and what we tried to impress upon the Committee on Immunization Practices. Our key point really focused on older patients and the idea that many older patients right now are struggling to get access to these vaccines, and there isn't enough uptake in their usage. And that is leading to a greater risk posed to the wider community because not enough people are taking these vaccines. ACIP made a proposed guideline change that essentially said that patients' attestation or patients' own ability to say that they require this vaccine or don't require this vaccine is enough evidence for the risk factor of whether they should use it or not. The big problem with this is that it forces pharmacists and non-primary care providers to essentially disregard their own judgment based on the available evidence, which really goes against the key practices that they are taught as a healthcare provider. So one of the big changes that we were hoping to impress upon ACIP and hope that they would make this change moving forward was that we want to make sure that healthcare providers are not in the position where clinical decisions are conflicting with the limitations that they might be facing in a community setting due to receiving incomplete information. Big part of this stems from the fact that many patients across the country, their entry point into healthcare and the place that they go to receive most of their vaccines is a pharmacy, their local pharmacy. And oftentimes, when you go to a pharmacy and you ask for a vaccine, they're not looking at your entire healthcare record. They don't have access to your entire healthcare record. So you're asking pharmacists to essentially trust the patient 100% of the time. And what we were asking for the change to be made, and let me just say, we knew ahead of time that they weren't going to make the vote regarding the RSV guidelines today, but we still felt that because it was the key point of the discussion for the rest of the topics, that it was important for us to make our statement heard so that when they were going to pick this up and make a vote, that this would be considered. And the idea that we really want to impress is that physicians and pharmacies and providers should be able to make these decisions based on their clinical knowledge of the patient and also what they know of the vaccine itself. The idea really stems in that we're trying to make sure that vaccine uptake or vaccine usage increases in as many ways as possible. And we want to make sure that patients understand that this is safe, effective, and they should be able to access it at all of the easiest points of the healthcare system.
Thanks, Corey. And you've just mentioned pharmacies, you've mentioned older adults. So now I want to move on to the next question, which is GHLF raised concerns about the clinical risk criteria for patients aged 60 to 74, especially because these guidelines may be challenging to implement in community pharmacy settings. So, Corey, could you explain these challenges and why they might be problematic for vaccine access? And I'm also thinking about a recent article highlighting the abysmally low RSV vaccine uptake this year.
Yeah, so most patients around the country, their access point to a vaccine is a pharmacy. And community pharmacies are very oftentimes the easiest access point in the US, especially for seniors in low-income areas where you have to deal with a lot of ethnic and racial minorities that are oftentimes overrepresented in these areas. Pharmacies play a really crucial role in providing access to the RSV vaccine. So one of the key points we wanted to make sure was stressed is that the pharmacists themselves should be empowered to make these clinical decisions. We were hoping that ACIP would reassess certain clinical risk criteria so that pharmacists can apply the risk criteria confidently and accurately without kind of just relying on trusting the patient, without compromising their professional integrity, so to speak. A big point of this and what we were trying to do specifically with regard to the risk criteria for patients aged 60 to 74 was we're trying to get ACIP to align its recommendations with FDA labeled indications. So many healthcare providers are very accustomed to adhering to the FDA approved package insert, which basically offers clear, actionable guidance for prescribing or administering medications or vaccines. If ACIP were to align with this guidance, it would effectively assist healthcare professionals in safely delivering vaccines while also ensuring that broader access for high-risk populations most in need of protection against RSV are protected. So the goal, again, is to make sure that the greatest number of patients have the greatest amount of access to these types of very important vaccines that will protect patients.
And pharmacists really have a large role to play here. So many patients rely, as you said, on pharmacies for accessible healthcare. So let's dive deeper into how these guidelines impact healthcare providers, especially pharmacists. So obviously, I'm turning to Robert now as a pharmacist. Robert, I would love your take on this.
So a couple of things. Number one, Corey covered it really well, right? This whole self-reporting attestation that they ask the patients to do and the healthcare professionals to agree to, it's really goes against the training of any healthcare professional, and just not pharmacists, right? As Corey mentioned, this is pharmacists and healthcare providers that may not be necessarily the main physician for the patients. Let's imagine if a patient walks into a clinic and wants to get the vaccine, and it happens to be a physician who's not their primary care provider. How's that individual going to know and be able to assess the patient with having some of these illnesses that supposedly actually are risk factors for qualifying the patient to get it. So the CDC, ACIP saying, oh, well, never mind. If you don't have the information, you can just take the patient's word. It goes against every bit of training a healthcare professional goes through, which is the clinical judgment. Yes, it's important to have a discussion with the patient. Yes, it is important to have that decision-making done with the patient. But you can't solely rely on a patient telling you that they have chronic renal disease or they have chronic liver disease or they have hypertension if you don't have that information, whether it's to their medical records or through their pharmacy records. And Corey did a great job of explaining that. The other thing, Ben, I want to go back a little bit. One of the things that we didn't cover is the pneumococcal vaccine issue that Corey also testified upon. And that's also important because that required patients to go through this risk-based criteria to get access to the pneumococcal vaccine. And good thing we testified and exactly what we told ACIP. We don't say that GHLF was the reason that ACIP did this, but I think they listened to a lot of people and they changed the criteria that anybody 50 and older is recommended to get the pneumococcal vaccine. And that's exactly what our recommendation was, to get away from this risk-based criteria. But, Ben, it's important for us to really talk about this whole issue of patients having access to medicine or healthcare in non-necessarily primary care settings, whether it's a pharmacy or a clinic or an ER or an urgent care center. And one of the things, I know you've brought it up in the past with regards to where you lived in France, is the ability of patients to have access to their medical records and be able to share that information with any healthcare provider that they choose to. We've had a very difficult time in the US to come around to do this, and I want you to talk about your experience of how does the French system work, because clearly I've never understood this, and I want to hear Corey's opinion on this too, is that as patients, why don't we own the medical information of our own healthcare? And it's somebody else, it's a third party, whether it's the physician or the pharmacist or the insurer or the PBM that owns this information, and we don't have access to it. And I know you've talked about it. Please bring up what happens in France as a patient and how you have access to that information.
Yeah, well, that's a great question. And somehow I knew this would come up on the podcast. So, before diving in, let's quickly go over how the French and the US healthcare systems differ in structure and funding, because it sets the stage for understanding their approaches to digital health records. So you have the French system that operates on a universal model that's funded primarily by government taxes, lots of taxes, and it offers comprehensive coverage with low out-of-pocket costs. And in contrast, we have the US system that we all know that relies on employer-sponsored and private insurance, and that leads to higher costs for patients and more varied access to care. So, that said, I'll just admit that the French healthcare system or model is very costly, so we have to keep that in mind as I'm talking. Getting back to your question, over the years, France has developed digital health record systems that allow healthcare providers controlled access to patient information, which makes it much easier to coordinate care and manage costs. There are two main systems that I can think of. There is the system that we call the carte vitale, which is the health insurance card. And then there is the dossier médical partagé, the DPM, which translates to shared medical files. So I'll start with the health insurance card. It's a Social Security issued card that contains essential administrative information. So that's the patient's identity and Social Security number, health insurance coverage details, and the primary care physician details. So when patients present their carte vitale at a provider's office, it streamlines the reimbursement process, meaning patients don't usually have to pay upfront for medical expenses. Instead, what happens is that the provider bills Social Security directly, covering a significant portion of the costs based on the patient's plan. And then, so getting back to our DPM, the shared medical files, they're accessible to patients and providers alike through a government portal. It's a secure digital health record that, with patient's consent all the way, it allows healthcare providers to access your medical history, lab test results, imaging reports, hospital discharge summaries, vaccination records, allergy information, and current medications. So that's a lot of information. And the shared medical files, they greatly help with care coordination, especially for people with chronic conditions, by ensuring that critical health information is readily accessible when needed. So what I can say is that the French system is a centralized, government-led approach that contrasts with what we have here in the US, where multiple providers and platforms like MyChart and MyHealth offer similar features. But in the US, the apps are typically tied to specific healthcare networks, which can complicate coordination when patients see specialists outside of their network. So I used to live in New York, right? And I moved to Indiana a few years back. And in the process, I also changed insurance. And then, I was still getting accustomed to the US healthcare system. I never really thought about grabbing all that information on my different portals. And now I'm kind of struggling, having changed providers, health insurance, everything. And just to grab that information that is mine, my own health records that are mostly now digital, it's been a real struggle.
Look, I'm a chronic disease patient. I have a chronic disease. I want to have access to my medical records directly from all my providers. And that's the key here, is that the patient should own the data, not the other entities. And I do want to hear from Corey, because I know that he has experiences both as patient advocate, as a policy expert, and as a patient.
Yeah, it's a really interesting question. I think it's something that I've always really thought about with regards to the US healthcare system. It's basically a big jigsaw puzzle. You have Medicare and Medicaid over here. You have private health insurance over here. You have Social Security over here. You have Veterans Administration over here. It's a big jigsaw puzzle. And that continues to be the case when you talk about medical records. Now, I will say it's gotten better. It has gotten a lot better in the sense that now most healthcare systems utilize digital records. So you are able to access them much more efficiently than you used to be. When I was first diagnosed with diabetes 13, 14, 17 years ago, it was much harder to find this information because you would have to call your doctor. They'd have to then make sure that they're sending it to the right person. It was usually over a fax system, which we don't really use faxes anymore, which is beneficial to us. So it has gotten better. But a lot of it also comes down to something that Ben, you mentioned, which is, as a patient, I have been pushed to the point where all of my providers are in the same healthcare system. They are all part of New York Presbyterian healthcare system. It goes for my endocrinologist, my gastroenterologist, my primary care physician. All of the people that I see are on the same system, because when I take a test with one of them, when I have my next appointment with a different one 3 months later, I don't need to get them to send the records to them. That physician already has access to it because they're part of the same hospital system. So I'm very fortunate that I was able to do that. Many patients around the country are not able to do that. They don't have the luxury of being able to say, I want to be part of this system and only this system, and get all of my providers to do that, because also most patients don't think about finding a provider like that. They think about finding a provider based on, oh, I've read the reviews on this provider and they are the kind of provider I want to go to and they are covered by my insurance. They don't oftentimes then say, wait, are they also part of the hospital system that my other team of providers are? So again, it kind of adds to that jigsaw puzzle aspect to it, where you're not picking a provider based on the system, you're picking a provider based on the things you want out of a provider, which is what you should do as a patient. Now, the easiest thing to say about how patients can own their medical records, so to speak, is become a little bit more tech savvy, learn how to utilize these things like Ben mentioned, MyChart, Epic is another healthcare system, and learn how to find the information you need so you can oftentimes download your entire healthcare record so that you're able to keep it in your own files. But again, it relies on patients being a little bit more tech savvy than the average patient is. And while it is improved over the last 15 plus years, it is still not at a point where, similar to the French system, where they necessarily have true ownership of their records.
I just want to emphasize the last thing Corey said, ownership of the records, ownership of their data. And Ben, we've had this conversation in this podcast, and I want, Corey, you can reflect on it. The reason that we don't, as patients, have ownership of our data is because there's an arbitrage system where this data is bought and sold by various entities outside the patient. And there's a huge market and profitability incentive to keep this data away from patients' ownership into the hands of these other entities, whether it's the insurer, the PBM, the hospital system, the physician, the pharmacist, whatever it is. And because of that reason, it's just heartbreaking to see how patients are not getting the appropriate care because there's a financial incentive to keep this into the hands of others other than the patient. And guess what? When they make money off of it, the patient doesn't make any of that when they are buying and selling this data.
Right. Well, now I think is a good time to take a look at potential solutions. So, Robert, what would aligning ACIP's guidelines with FDA-approved indications mean for healthcare providers, and why does GHLF believe this alignment would make a difference in administering RSV vaccines?
So, FDA approval of a vaccine, package insert for a vaccine, every healthcare professional is trained to be able to read, interpret the package insert. It's the federal approval process for the medicine, whether it's a vaccine or medicine. So I think aligning as much as possible, if not fully aligned with the package insert, will allow pharmacists, physicians, any healthcare professional who has the ability to access the package insert to be able to then make a judgment, a clinical judgment based on the approved criteria. The more ACIP and CDC sways away from the package insert, the more confusion it creates. And because of that, at GHLF, we basically say, look, two things. Number one, we want you to align 100% with the package insert, but if you're not going to do it, then you need to make the criteria of your recommendation much more achievable in a community setting, whether it's by a pharmacist, the clinician that is not necessarily the primary care physician, a nurse in a clinic, urgent care center, so on and so forth. So ACIP needs to take these to heart and be able to do so. Then they can basically go into creating criteria and all these other things that are more achievable if we had a more doable system with regards to data transfer.
Well, thank you, Robert. So my take on this is that clear, consistent guidance aligned with FDA recommendations could improve vaccine access and empower healthcare providers to deliver safer and more effective care. One big word that I heard throughout the recording too is ownership, and I feel like that's a big one for patients in the States. We are in a purely capitalistic system, and the patient is affected by that. That's also like maybe a step forward for patients and hopefully have more ownership of their own information. But Robert, you're the expert and you have the last word.
Well, first of all, I want to thank Corey. He did a great job, as always, representing Global Healthy Living Foundation, but more importantly, representing patients and the voice for the patients. ACIP does a fantastic job. CDC is a great organization within the health and human services, and they should continue their work. But there are some realities. Majority of adults, 80+%, if not close to 90% of adults, receive their immunization in a pharmacy and a non-traditional healthcare setting, whether it's the primary care physician. ACIP needs to recognize that. Currently in the ACIP advisory board, there are no pharmacists that are represented as a profession. That's one of the things that we need to come to fruition, is that we need to get the voices of the patients and the pharmacists and other healthcare professionals that interact with patients in that committee to be able to vote, to be a voting member. Next, we need to have ACIP align their recommendation as much as possible to the FDA label. Every healthcare professional is trained to read and interpret an FDA label. You can easily do that with less confusion. Third, if ACIP is going to demand for specific risk-based criteria or age-based criteria that is not aligned with the FDA label, they may need to make it much more simpler and easier to interpret and administer in the community level where patients are actually getting their immunizations. And that requires a whole set of changes in our healthcare transfer of data and ability to be able to access that information. Lastly, it is sad to say, but ACIP and CDC saying that you should take the patient's word that they have the disease and just give them the vaccine, it goes against every sense of being able to take care of your patient as a healthcare professional. Whether you're a pharmacist or a physician, doesn't matter. And we need to recognize that. And we need to be able to say to ACIP that, look, we want to help patients. Immunization rates for adults are abysmal in the United States. We need to do a better job of getting vaccines in the arms of adults.
Well, thanks for breaking that down for us, Robert. And Corey, thank you so much for joining us today and for all of your insights. Well, that's it for us. So don't forget to subscribe to our podcast on Apple Podcasts, Spotify, or wherever you might be listening so you never miss an episode. And if you have a second, help spread the word by rating our podcast, writing a positive review, and sharing with your family and friends. It'll help more people like you find us.
Well, if you have any questions, thoughts, or suggestions for us, by the way, this is our season finale for season 5, right, Ben?
That's correct.
So we're going to take a hiatus, but we'll be back end of this year, and definitely we'll be on next year as new Congress comes into play and policymakers take their seats. But if you have any questions, thoughts, comments, please reach out to us. You can email your information to podcasts@ghlf.org. And again, I want to thank Corey for his work and Ben, as always, for your work. And as we say in Hollywood, it's a wrap on my end for season 5, but we look forward to season 6.
Yeah, we'll be back. And in the meantime, make sure you take a listen to some of our other great podcasts on the GHLF Podcast Network. You can find all of GHLF's podcasts at ghlf.org/listen. He's Dr. Robert Popovian.
And he's Ben Blanc, and as my alma mater, Hollywood High School, we will always say, it's a wrap for season 5. See you next time.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.